It is 2:02. All right, good afternoon, everybody. Good to see you all. It is 2:02, and I will call to order the meeting of the statewide substance use response working group at July 9th, 2025 at 2:02. Please call the roll.
Chelsea Cheatham. Dr. Dixon.
Here.
Oh, Chelsea, okay. Senator Doniate. Dorothy Edwards. Attorney General Ford.
Here.
Assemblymember Golding.
Here.
Assemblymember Gray. Dr. Shayla Holmes.
Present.
Jeffrey Iverson. Jessica Johnson. Nancy Lindler. Debbie Nadler.
Present.
Angela Nichols.
Present.
Christine Payson.
Present.
Eric Schoen.
I'm here.
Steve Shell.
Here.
Dr. Slamowitz.
Presto, Dr. Simowitz is present.
Jessica's back.
Senator Jeff Stone. I'm going to go through the top again. Jessica Johnson.
Present.
Great. Attorney General, we have a quorum with 12 members present.
All right, great. Thanks so much. We will move on then to agenda item number 2, public comment will be received in person at either of the locations listed above and via the Zoom meeting. Public comment shall be limited to 3 minutes per person. No action may be taken upon any matter raised during a period devoted to comments by the general public unless, until the matter itself has been specifically included on an agenda as an item upon which action may be taken pursuant to NRS 241.020. Members of the public are requested to refrain from commenting outside of the designated public comment periods unless specifically called on by the chair. SCI staff will mute people speaking outside of public comment unless unless and until called upon by the chair. And please do not use the chat for any items other than technical support as this becomes part of the public record. With that, do we have anyone on the screen for public comment?
Attorney General Ford, we have Debbie Nadler raising her hand.
Ms. Nadler, what do you have for us?
Hey there. First of all, I want to make sure that this is recorded. Our public comments, are they recorded in our agenda or they're not? Can somebody answer that?
We've been recording since I started us off.
Okay. All right. All right. So here goes. My name is Debbie Nadler. You all know I've been on this committee for 5 years now. But I want to be clear. There originally was not a seat for someone like me. No one invited a grieving mother to sit at this table. I had to push my way in and make a space, not just for myself, but for every parent whose child was taken by this crisis. I didn't come here with a title or a grant. I just came here with a truth that I don't know if the room wanted to face, but I know it's still not facing. We sued on behalf of our dead children. We wouldn't have a lawsuit if it weren't for them. My son Brett was one of them. We got $1.2 billion and handed $300 million to lawyers. But what did the families get? No trauma support, no grief services, no help for the siblings, no money to light the Las Vegas sign purple on Overdose Awareness Day, the one day to recognize the loved ones lost in the state. The grieving family members had to raise that money ourselves. Dozens of parents and loved ones came together to do what the state wouldn't do, and that's to honor the lives that were lost. We've also been the ones to fund the memorials, public outreach, and community awareness. Why I believe this committee has prioritized on bureaucracy, harm reduction, and infrastructure. But there's something that's been left behind, and that's primary prevention and mental health awareness for the kids in schools. All I've asked for the past 5 years or more, again and again and again, is primary prevention and mental health. There's still no statewide campaign, no meaningful classroom education, no early intervention. A few programs in a few districts is not prevention. It's delay and it's failure. While everyone's waiting, our kids are dying. Our state is the only state in the country where overdose deaths increased in 2024 by 4%. That might seem like a small number, but it's a big number. That's not just failure, it's neglect on our part. We, the parents, were on the front lines. We saw what worked, we saw what didn't. We know what needs fixing, and we know that prevention is a big key, but it's not being funded. And perhaps that's part of the reason why the crisis is out of control. This epidemic doesn't care if our children are rich or poor or Black or white. They don't care if you live in Summerlin or rural Nevada. One day it could be, God forbid, one of your children or your grandchildren or a relative. And I just wonder to myself.
Ms. Nadler, we're coming up on 3 minutes, ma'am. I need you to wrap it up.
Because this is how it happens quietly, suddenly, and permanently. At this point, I have to ask myself, am I here to make a difference or am I here to be tolerated? I joined this committee because I knew in my heart it's what my son would have wanted me to do, to help others like him, to reach someone else's child before it's too late. But the truth is, every time I speak, no one listens, and it feels like he's dying all over again. We see where the money's going. We see where it's not. Our state was entrusted with a responsibility that came at the cost of our children's lives.
Ms.
And I'll
Nadler,
close
I
with
need you to
this.
wrap it up, ma'am.
I need to
3
finish
minutes.
this. I can no longer in good conscience sit on this committee because my voice and the voices of grieving families are not being heard. Our children are not being seen. Our pain is not being respected. I didn't sit up quietly. I signed up to fight for families still suffering, and I signed to protect the children who are next. Some of you may feel relieved that I'm stepping away, but I want you to take my absence as a challenge. Who among you is going to stand up and fight for the vulnerable? Who will speak for the victims who no longer can? I ask you next time you meet to think of my words and to think of the thousands who've lost their lives and the thousands more to come. This is your moment. This is your challenge. I challenge you all to meet with every victim, to see the face of every lost loved one, to hear the struggles, the stories, to look the grieving parents in their eyes and feel their pain, and then ask yourself, are we doing enough? I did this to make a difference, and apparently I'm not worthy of this committee as I don't hold an important position. I was the reality, a victim, and a person with lived experience. I urge you all to take a moment to genuinely feel for us. Thank you, Jessica Johnson. I adore you. I love you for everything you've done. I'm sorry. This is my last day. I wish you all good luck. I feel I'm no longer worthy of the committee, and I'm signing off. Thank you so much.
Thank you so much for your comments, Ms. Nadler. With us being in public comment, I'm going to take a couple of minutes and into some comments in public comment as well. Let's be clear about the status and the purpose of this committee. It is to make recommendations to an entity that actually makes decisions on how monies are spent. This committee was never intended to spend money, to allocate funds, or to do anything in the arena of exercising authority over how monies are spent. I commend this committee, which has met over 5 years, in the work that it has done to do exactly what it was called to do, make recommendations to the Advisory Council for a Resilient Nevada, which is housed within the HHS department of our state government. And I also commend HHS for doing the yeoman's work on ensuring that monies have indeed been spent on survivor services, on services to help victims and survivors of the opioid epidemic, and beyond that. So, I want to take an opportunity to offer some thoughts that are contrary to some others that may be out there. And again, I look forward to working with the members of the search committee who are indeed dedicated volunteers who are putting in yeoman's work to try to provide services and recommendations on how to best to respond, by the way, not just to the opioid crisis, but to substance use and abuse of a wide range and a wide sort of substances that are out there. And in terms of the monies that have been spent, recognize that we should give credit where it's due, and that is to the outside counsel that has brought in well more than $300 million worth of support and services. The state would not have $1.2 billion of monies into this state had it not been for the exercise and the efforts of outside counsel that was approved by the governor and by the legislature in order to affect us, to assist us in effectuating these positive goals. And so with that, is there anyone else here who wants to speak in public comment? Yes, ma'am. Dr. Kearns.
Yes, I just wanted to highlight that the 2025 Southern Nevada Substance Misuse and Overdose Prevention Summit will be held on August 14th from 8 a.m. to 5 p.m. here in Vegas at the UNLV Strip Pavilion. There is a $25 registration fee, but there are a generous amount of scholarships. The scholarships just cover the registration fee. They do not cover travel. And there are still open slots if anyone wants to sign up for that. And it is in the materials, the flyer for it is in the materials for the SURG meeting today.
Thank you, Terry. That was Terry Kearns for the record, and I forgot to mention that I was Aaron Forward for the record. Anyone else here for comment? Yes, sir.
Giuseppe Mandel, up to the Healing Recovery. And AG, Dr. Kearns and everybody here. We do thank you as the public for all the work that your office has done and the outside counsel. We do. I came in late, so I apologize. I didn't hear everything, but there is a lot of us in the public that do thank you for all the hard work that you guys have done. And then I just wanted to just say one thing, and I enjoy these meetings. Thank you for allowing me to sit in and learn with you and the public. And I would like to just base off a couple of people in my service. We would like to hear a little bit more in future references, a little bit more about treatment as well, and what we're doing it with as far as the state and in one of our major gaps. We made huge strides as far as with a lot of different programs, as far as peer navigators in hospitals and the buprenorphine programs and stuff like that. And we're starting to kind of miss that key gap of what do we do with them from there. And we'd love to hear more about different actual treatment programs for that next step so that we can try to get these numbers down and reverse from there and learn more about those programs and if there are funding opportunities for some of the good programs out there. I think it would be great to invite some of those companies to the table to hear about what they're doing, where once we get them capped or in the ER, or we got the prevention side, we've got the harm reduction side. What are we doing about the treatment side? And then that piece of recovery. And we're missing it a little bit in the state, even though we're making strides. And a lot of us in the public field would love to hear more about that part. And thank you guys very much. And again, thank you for allowing me to be a part of your meeting, as always.
Thank you. I have someone else for public comment. Yes, ma'am.
Yes, Maureen Strong from Southern Hills Hospital, and I'd like to tag team with Giuseppe in his comments and bring you up to date with what's going on at Southern Hills. I am the program director for an addiction medicine fellowship. It's the first and so far only one in the state of Nevada. We have 2 fellows per year because we lack funding to meet the 4 that we could have per our accrediting body, the ACG. In this past year, we began to pilot services in the hospital setting to provide addiction medicine consults to raise the bar for evidence-based treatment in the hospital setting for individuals coming in withdrawal or with other complications of their substance use disorders. And I am really pleased and honored to say that 2 of my recent graduates are going to be staying on board and helping me to build that service. Once we establish that, we look forward to expanding that to other hospitals, first within our system in HCA and then on to other hospitals that I've already been in discussion. We're at the physician workforce level. And so we're working very hard to train residents and fellows throughout the city through our services. And Dr. Dixon's been involved with that as we have many residents and students rotating through the behavioral health group.
Thanks so much for that public comment. Is there anyone else here in Vegas for public comment? All right, back to the screen for public comment.
Yes, sir. Online, we have Stephanie Cook.
All right, Ms. Cook. Ms. Cook, are you there?
You may need to push *6 to unmute. Oh, there we go.
Can you hear me?
Yes, we can. Ms. Cook,
Okay,
go
I don't know
ahead.
if you
have
can
3
see
minutes.
me, but okay. My name is Stephanie Cook. I serve as the Nevada State Opioid Treatment Authority. I am housed within the Bureau of Behavioral Health, Wellness, and Prevention within the Division of Public and Behavioral Health. I just want to share that our Bureau is finishing up our strategic plan, which will inform a lot of our funding decisions for the next 5 years. In that whole process, we took into consideration all the SURG information, all the ACORN information, and all the various other things that our state has out there. Once that's released, we'd like to come and present it to the SURG. So I'm putting that out there for consideration. One of the cool things that we're working on soon as well that I wanted to put on your radar was a statewide anti-stigma campaign as it relates to substance use disorders, and really focusing on a couple key factors of stigma that we want to promote and educate others on. And so we're taking it from the state level approach to really get a good brand out there, an anti-stigma campaign brand for the state. So happy to also get feedback from this body on that as we work through that campaign material. So happy to connect with anybody that's interested in that work. Again, Stephanie Cook as the State Opioid Treatment Authority. Thank you.
Thank you, Ms. Cook. Appreciate your public comment. Is there anyone else on the screen for public comment?
No, sir.
All right, do we have anyone in Reno for public comment or in Carson?
No one for public comment in Carson.
Okay. Great, thank you so much. We will move on then to agenda item number 3, a review and approval of the minutes from April 9th, the SURG committee minutes. They have been distributed, and are there any corrections? If not, I will entertain a motion to approve those minutes.
I'll make a motion. Dr. Dixon, I'll make a motion to approve the minutes.
We have a motion. Could I get a second?
This is Sheila Holmes. I'll make a second.
All right, we have Sheila Holmes with the second. So it's been moved and probably seconded that we approve the minutes from April 9th. Any further discussion? Hearing and seeing none, all in favor say aye. Aye.
Aye.
Aye.
Aye.
Any opposed, say nay. Motion carries unanimously. Thanks so much. Moving on to agenda item number 4, an update on opioid litigation, settlement funds and distribution. This will be offered by my chief of my Consumer Protection Bureau, Mark Kruger, who incidentally, I wanted to also commend for the hard work you've done to ensure we bring in $1.2 billion to the state for opioid recovery and abatement efforts. Mr. Kruger.
Thank you, General Ford and everyone else. Good afternoon, or good morning, or good afternoon, I guess. Mark Kruger, Chief Deputy Attorney General with Nevada Attorney General's Office, for the record. My update is finally we've made it to the point where we have a settlement in the Purdue bankruptcy and with the owners of Purdue, the Sacklers family. That settlement will amount to approximately $57,941,000 and change to the state of Nevada. That will be distributed through the One Nevada Agreement on allocation of opioid recoveries. The state's share of that will be approximately a little bit short of $20 million, so $19,900,000. So it's been a long time in getting there. I know we've updated you on Purdue for quite some time, but all 55 states and territories have agreed to the settlement. We're in the process of getting local government sign-ons. They're getting ready to set those for their agenda meetings, and over the next course of the next couple months, we'll get those all done, and that settlement should be wrapped up. I anticipate by we should probably see payments by June of next year at the latest. That brings us up to date, and as General Ford said, with that settlement, it puts the total recoveries at just over $1.2 billion. During my research, what I have discovered is that that recovery then puts us as the 3rd most successful state by per capita, following only 2 other hard-hit states, West Virginia and New Mexico. So we've done a fantastic job, and General Ford's leadership has been amazing in this area, and the numbers speak for themselves and the recoveries. As you guys know, Dawn Yohe will probably be presenting the efforts they're making to spend the money on programs and services to really help Nevadans and save lives. That's my report. I'm open to questions.
Mark, excuse the leading question, but remind the committee that we do not, as the Office of Attorney General, make determinations on how monies are spent.
That is correct. Mark Kruger for the record. We are the ones who bring the money in. That's our charge. And the Department of Health and Human Services by statute has been assigned the task of figuring out how to get the money to the programs and services that will best address the opioid epidemic, which is ever changing, and they change with that. And that's why your work here on this board is so important, because you make recommendations to Department of Health and Human Services so that they can incorporate it into the state plan and as they make those changes.
Thank you, Mr. Kruger. Are there any questions for Mr. Kruger? Any questions for Mr. Kruger? Any on the screen? Very good. Thank you, Mr. Kruger. You are free to leave, and have a great afternoon.
Thanks, everyone. Thank you, General Ford.
You're welcome. Moving on to agenda item number 5, current trends in substance use. I will say that I will be relying upon my vice chair to take over the meeting. Thank you so much, Mr. Shell, for always being available in that regard. But with that, let's move to an update for opioid overdose prevention activities from Cassett. 15 minutes allotted for this for question and answer. Michelle Berry, Morgan Green, and Morgan Green will be presenting. You have the floor.
Thank you. This is Morgan Green for the record. I am the project manager that handles the OTAC as well as the mobile units for Cassett. So I appreciate being here today. So we do receive funding specifically from DBPH to support both some of the SOAR 3 no-cost extension funds to support the harm reduction distribution of supplies, as well as some evaluation. And we do receive funding from FRN, so the Fund for Resilient Nevada, to support the OTAC and the mobile units. So what I'm going to be going over today is just kind of a year in review in regards to our OTAC, which we call NOS, just so you can see what was accomplished in the first year of funding, as well as a mobile unit update, and then specifically harm reduction, but naloxone in particular, and how much has been distributed over the past year. So for NOS, which is the Nevada Opioid Center of Excellence, funding began in January of 2024. Website was launched in April, and the first trainings began in June. So this really has been about a year of this program being completely active. Within that time, we've completed 28 live public events that people had the ability all over the state to attend. For those who were able to attend, most oftentimes, continuing education credits were provided. So it was a good opportunity to encourage people to be part of this as we try to, again, empower our professionals and our community members to work with populations who are struggling with opioid use disorder. And within those events, we also included 3 extended learning series, which were targeted to special populations. In addition to those public events, we also had 12 targeted technical assistance events, and those were working oftentimes with programs who were just getting off the ground. So we had several different agencies who were traditionally mental health agencies that were also adding on substance use treatment into their programming. So we work specifically with them to help build some of that programming into place so that they could go up to fidelity. We also produced 21 different podcasts. These podcasts specifically highlight the work that our behavioral health professionals do in the communities. We really want to highlight the work that's being done to help promote different ideas, what's possible, what are some of the different ways to approach in regards to different populations that we work with. And then lastly, we had 50 different outreach events we had staff members who were present at working directly with the community. So these are the topic highlights that we came across. Several of these came out of the needs assessment that was completed for the Fund for Resilient Nevada. Others were specifically requested. So we see a lot of some of just the basic 101s, as well as some that were kind of highlighting some of the laws that came into place, understanding Good Samaritan Act versus drug homicide laws, Assembly Bill 156, which is targeting pharmacists. Over the last 6 months, we really had the learning series. 3 of them, one highlighted working with tribal populations, one highlighted working with ACEs in regards to early identification and different approaches. And then the third one was looking at doulas in particular. So we wanted to make sure we were hitting different populations and different professions to ensure that we have a full, well-rounded professional kind of approach to all of this. So in regards to the outreach, we really tried to spread it. As you'll see, this was the first year, so we're a little bit thinner when we look at the southern part of the state. We just placed somebody into an outreach coordinator in the southern part of the state, so we're hoping over the next year we can really kind of bolster that activity down in Clark County. We also really made sure that, or we're trying to highlight rural locations just to ensure that we have boots on the ground, people are present and making those connections. For special populations, the activities that we worked with, we had several that were targeting youth, tribal, one was veteran specific. And then our staff did help put together the Esmeralda Health and Resource Fair that was highlighted in Goldfield, just to ensure that multiple resources came into that very resource thin area. And then you can kind of see who the target audience was across the board. So we had some that were behavioral health specific, many that were community member specific. So just making sure, again, members of the community themselves have access to this information. And then 9 were for working with public officials and just kind of making sure everybody has the same information. So some of the major upcoming events that I just want to point out, we have one that's happening in August, which is supporting pregnant and parenting people who use substances up here in Washoe County. It's going to be both in person for the first session, and then it's going to have a virtual learning series attached to that. That is working specifically in partnership with the Washoe County abatement dollars. So we want to make sure that we are, again, working with the communities themselves. And then another one is CIT training for rural dispatchers. So that's been one that's directly requested from Bill Teal, who has been working with the jails out there to try to, again, bolster just the resources that are out available. It will be held in person, but there's also discussion because we know not all of the dispatchers are allowed to leave their job at one point in time. That might create a 911 crisis. So we're also working to try to set up some scholarships for the individuals who are unable to attend in person. Also new in the next year for NOS, we have 2 new centers that are being created within the organization. So the first is going to be Nevada Prevention Technical Assistance Center. This one is going to be working with community coalitions, nonprofit agencies, different local government agencies, including schools, school districts, private businesses, all of that to work on bolstering prevention activities. So making sure, again, up to fidelity that we are sharing that information and assisting with kind of that development for different organizations. The second one is a screening prevention intervention collaboration. This is going to work on, again, universal screening, so early identification for people who might be stepping in the wrong direction. And that's going to be, this is specifically targeting community healthcare workers, criminal justice professionals, and adolescent service providers. All right, so on to the mobile units. So we do have the 3 mobile units. We have finally figured out the funding issues that were kind of holding us up. So right now, 3 organizations have been identified. Roseman's going to be covering the western central portion of the state, in addition to running these mobile units, which will be providing really kind of telehealth services on the ground, community health worker services, peer support recovery services. And then they can work with the pharmacies themselves to help prescribe different medications for opioid use disorder. So we kind of want to make sure that we're working with the communities again. Roseman's going to be covering the west and central portion of the state. Vitality is going to be the northeastern portion of the state, and then West Care is going to be the southern portion of the state. All of these are going to be focused on the rural areas. 1 award has been completed, so we expect that's going to be with Roseman. We expect a tentative launch date early September to get them on the ground and going. They've already staffed up. The other 2 awards are still in process, but we're really close. So we're hoping to have everything done by the end of summer. And that picture was the inside, just so you guys had kind of an idea of what they look like. All right. And then lastly, the harm reduction supplies that have been distributed over the past year. So we report a little bit differently in Southern Nevada Health District. We tend to report in 2-dose units. They report in 1-dose units. So just so you guys kind of get an idea of how the numbers are so different. But for naloxone, we've distributed a little over 56,000 units over the past year. Of those, majority of those are going to our community partners. So these are the partners that distribute directly out into our communities. So they have received the bulk of the naloxone. Law enforcement has received a little over 2,000 units. And then for the test strips, fentanyl test strips were far more popular. We had over 100,000 units that were distributed. And then xylazine had a little over 58,000 strips that were distributed. All right, so I just wanted to give you guys a quick rundown to some of the activities. If anybody has questions, please let me know.
Morgan, Vice Chair Steve Shell, for the record, we really appreciate your great presentation. Lots of very beneficial information. And as Morgan said, we will open it up to questions now. We have time for a couple of questions for Morgan. So do we have any questions from our SURG members? I see Jessica Johnson with her hand raised. I will turn it over to her.
Thank you, Vice Chair Shell. Just for the record, please driving my camera if I'm on hotel Wi-Fi. And I was wondering, I think you might have highlighted this and I was taking notes and missed it. Can you share a little bit more about the mobile units and specifically what services they'll be providing, and if there's any specialty populations or considerations as we think about how to support that scale up?
Perfect. So the mobile units, this is considered a pilot project. So because they are funded through the Fund for Resilient Nevada, they are specifically targeting individuals with an opioid use disorder or at risk of an overdose. So that's the primary population that is being targeted. And then within that, we've also requested that they work specifically with the jails that have been working with Bill Teal to help kind of support some all-around services, because a lot of those jails don't have access to that. The one unit that is going to be a little bit different is going to be the one that's run by Roseman. They are also going to be able to offer like pre and perinatal services for individuals of childbearing age as well, just because they have that ability to do so.
Great. Thank you, Morgan. Next, I see Assemblymember Golding with her hand raised.
Thank you. Thank you so much for the informative presentation. I'm wondering if you do any follow-up on the naloxone and test strips. Do you have any sense of how many of those are actually being used? Do you do any follow-up surveying? Because distribution is quite different than actual use. So it would also be very informative to find out how much of those are actually being used in the field.
That's a great question. And it's something we constantly are trying to figure out. But we do, so all of our community partners, so you guys got the community partners numbers there. All of our community partners have also been asked to have individuals fill out a short survey as when they receive the unit, that really just kind of goes, how much are you getting? Where are you located? Like county wise, because we don't want people to be identified. And then if they're not doing individual distribution, but maybe they're doing like a care chest distribution, then how often is that box being refilled? Because then we know how much is going out to the community directly. So we do have those numbers on the back end. Obviously, we're not catching 100% of everything that's being distributed, but we have a pretty good idea as to how much is being distributed from that point. So we do have kind of some checks and balances to ensure that it's getting out.
Thank you for that. There's, and then the next step is, I think there are many community members that make sure that they have those supplies with them. The next step though is how many times are they actually being used?
So
and is
as
there
part of
some
that-
data collection on that front?
So as part of that survey, again, everything in terms of being used is always going to be voluntary. People can get a little cautious about that just because there's a little bit of distrust between this population and authorities. But as part of that survey, there is a question, is this a refill? And then if they say, yes, it's a refill, then it goes down to potentially, why are you getting this refilled, right? Maybe you gave it to your friend, maybe you used it, maybe you lost it. So we do have the opportunity to gather some of that information for how much is used. We update that number about every 6 months on the website, so you can see how many reversals have been reported back to us. Again, we know that's a very big underestimate, but it's the best information that we can do without creating a barrier for people accessing the naloxone.
Thanks. I'm sure that it's super hard to get that data, but it's just so critical. So thank you. I appreciate that.
And we have time for one last question. I see Chelsea Cheatham with her hand raised.
Yes, thank you. Thank you for that presentation, Morgan. I just had a follow-up question to Jessica Johnson's question. Can you tell me a little bit more about what services are going to be provided on those mobile units, like when it comes to medical services, testing?
Sorry, I completely failed that part of your question, Jessica, and thank you, Chelsea. So the units themselves, it's going to depend on exactly how they are staffed. They have all been given kind of an ideal staff, but we also know different regions of the state are going to have access to different people who are capable of staffing it, right? So at minimum, they're all going to be able to provide community health worker and peer support at the unit level. They all are required to have telehealth services backed for counseling services, as well as with a prescriber who's able to prescribe for MOUD at some level. Some of the units are going to have a counselor that's on the unit themselves, so they don't have to do the telehealth for that purpose. And then depending on how they are staffed, they also have an opportunity to do kind of primary care screening. So those are kind of going to be the basics. It's really targeting for individuals who don't have like treatment resources in their communities or aren't able to travel far enough to get access to those.
Okay, Morgan, thank you again for being here today. We really appreciate your presentation. So thank you. And we look forward to continuing to work with you in CASAT. So
thank you.
Mr. James Dardis. He is with the Fund for Resilient Nevada in the Office of Analytics with the Nevada Department of Health and Human Services. So I will now turn it over to Mr. Dardis. Hello.
Hi, my name is James Dardis, and I am an analyst with the Office of Analytics in the newly formed Nevada Health Authority. I'm in the DPH unit, and I'm the substance use team lead, and as well as the principal analyst for the Fund for Resilient Nevada. Today, I want to talk to you about the substance use landscape in Nevada, as well as introduce you to a very useful resource that I sourced for this presentation. Pardon me. Okay, so first I'm going to talk to you about Nevada's population growth, and then we'll go over some major trends in substance use, primarily opioids and stimulants, and some questions that are raised by the data. And then I will introduce you to the behavioral health epidemiologic profile for 2024. So Nevada's population, pardon me. Yes. Nevada's population grew from 2014 from 2.2 million to 3.2 million in 2023, increase of about 14%. This will set the context for interpreting absolute trends in substance use and in emergency department visits. I'm going to focus on age-adjusted rates throughout this presentation. And because we're using that as a metric, we don't really need this population growth, but I find it helpful because even where rates are steady, if population is growing, then from that we can infer a greater demand on the on our healthcare systems and public health systems. So throughout the 1990s, overdose deaths shifted from street drugs to prescription opioids. This was at least partially caused by the overprescription of opioids for pain management. In response to this, there was more government insight. More government insight did quell the prescriptions, but then a second wave of overdose deaths emerged from street analogs, heroin, namely. From that, we were introduced to the arrival of fentanyl. Fentanyl, with its strength and potency, this was the first time we really had to start to consider unintentional ingestion. That's when people are exposed to fentanyl accidentally, but with the potency of it, you know, from handling paraphernalia or searching someone, we were seeing deaths. Assembly Bill 474 revised the Nevada statute 543-226 in 2017, and this required prescribers with controlled substances prescribing license to register with the prescription drug monitoring program, the PDMP. The PDMP is state operated, it's CDNC supervised database that monitors the prescribing and dispensing of controlled substances. It serves as a tool to identify and present drug misuse while equipping healthcare professionals and public health authorities with timely insights into patient behaviors. In other words, we can see patient history. So since 2017, the opioid prescription rate has dropped from 785 Nevadans per 1,000 to 412. So if that area of it is effective, and if this was all we had to go by, the situation would seem to be looking up. But I think, as we know, that isn't exactly the case. Emergency department encounters for opioids have increased since 2018. So while the prescription have dropped by nearly half, ED visits have surged, which suggests that prescription control is only part of the picture. The illicit drug supply is filling the gap left by halted and reduced access to prescription opioids. It's very important to understand that in this graph, as well as every subsequent graph I will show you, these do not imply substance exclusivity. In other words, these opioid emergency department encounters are not strictly for opioids. Opioid was at least one of the substances involved in the encounter. So later, whenever you see a similar graph for stimulants, some of those counts are in this graph, and some of these counts are in that graph. demographically, male overdose is up 124% since 2019. For females, it's remained relatively flat. You see the male here in the blue. We're able to see disparities among different racial groups. The black line is that's the Nevada average among all demographics, racial demographics. The Caucasian above that in the yellow is it's above average, which kind of makes sense with non-Hispanic whites being the plurality in Nevada. What is alarming is the gray line for Black Nevada residents. They've surged particularly recently in recent years. Okay. So notice this graph, the title of the graph, not the slide: opioid deaths and death rates for Nevada residents. So not everyone who dies in Nevada is a Nevada resident. It's not in this report, but the preliminary death data for 2024 shows that over 200 people, and I think it's 258 people, died from a drug overdose in Nevada who resided out of state. And because not all states share details of when a Nevada resident dies in their state, this presentation will show only counts of persons who died in Nevada while Nevada was their state of residence. So their state of death was Nevada as well as their state of residence. Since 2018, opioid deaths and death rates have more than doubled. So if prescriptions are down and death rates are up, this raises the question, why? And neither the manufacture nor the selling of illicit opioids are regulated. You know, they're prohibited, but they are not regulated. So different potencies of drugs hit the street, and you're not going to be turned away from a dealer because he's already seen you twice today. You know? So moving to stimulants. We know what these are. There are many legal substances that we use every day, like caffeine. They're prescription medications, as well as street drugs, like methamphetamine, namely, and cocaine. So this time I'm going to show you demographics first. For males and females both, here on the left, the lines have been flat. So the line for males may not appear to be flat, but it mathematically it is. If you average these 2 points, we get something right about here in the middle. So this blue line can be thought of as being rather flat if we average those 2 local extrema. And then if we look at it racially, it looks about like the same picture as for opioids, but the numbers are so much smaller, you're going to get a lot more saw blade effect to show variation among each group. Just as well, ED counters are relatively flat. If you look at 2018 to 2019, you see a dip and then a bump. But again, if you average those, you get 4.4, which is the neighboring is 4.5 and 4.3. So this is, again, a relatively flat line. So emergency encounters for stimulants, namely methamphetamine and cocaine, are steady. But here's the deaths. Stimulant death rates are up 325% since 2014. Here's another why. So we may be able to tease this out with Suter's data, but my suspicion is that, right, recall that we're not implying any, we cannot imply any drug exclusivity with any of these. So many of these deaths involved opioids as well. So is it the cocktail that's killing people? If it was, I think that would show similarly in the opioid data, which it doesn't. So I suspect that stimulant deaths are, opioid deaths can most certainly be rapid. but they can also stretch out over hours. And in that time, when someone is non-responsive but breathing, you can administer Narcan, you can call an ambulance, you can take someone to the emergency department. Whereas with stimulants, people are dying, from cardiovascular collapse and hyperthermia and reasons that take over much more rapidly. So anyway, I raise these questions not as a disclaimer for the data, but really more of a feature. So when I show you the epi profile, it is loaded with information, but within information, there are plenty of questions, plenty of future areas of research. So as we've seen, opioid deaths are up and as well as methamphetamine. If you look at these, at a glance, they would appear to be neck and neck, but this entire bottom group is opioids. And this entire top group is non-opioids. So opioids are really leading the charge with death count. This is Suter's data, by the way. So if you go to a browser and you enter Office of Analytics reports and dashboards, you will get this page. At the very top is the behavioral health section, and halfway down is the behavioral health epidemiologic profile for 2024. This is put out. This is what I sourced for this presentation. It covers all varieties of behavioral health topics, and I used the statewide version for this. If you look at the 5 below, you will see breakouts for. It's the same report, but broken out for each behavioral health region. Here's my contact information. If I can better clarify or answer any questions having to do with this. And here's the website of my office. I'll be happy to take any questions.
Vice Chair Steve Shell for the record. Thank you so much for your presentation. We would now like to open it up to questions for Mr. Dardis. Do we have any questions for him today? See Jessica Johnson with her hand raised. I'll turn it over to Jessica.
Yeah, thank you so much. Jessica Johnson for the record. I appreciate you being here today, James. And glad to have these slides. I had just a tough time kind of following some of the places in the beginning, so I might try to follow up. As someone who has had an opportunity to look at these data over a long period of time, I do think there's perhaps a lot of important contextual information that some of our community partners and other groups could provide that might help us understand some of the descriptions of the ebbs and flows that you were finding. For example, I think the opportunity to learn more about stimulants and heat and deaths among folks who are unhoused and sort of what some of those intersections are would be really important for us to think about how to use these data to take action. I was wondering if you could go back briefly to, I think it's one slide for figure 80. Oh, 2 slides. Sorry, thank you. I'm not seeing the description of exactly, are these count data or are these rates?
These are counts. I'm sorry. Yeah, I should have covered that.
Okay.
These are counts. And again, these are
Okay.
like this can be more than one of these can appear on for a single death.
Right. Okay. Okay, thank you. I wanted to look at this slide a little bit more quickly and it went by too fast. Thanks for the opportunity to ask a question.
For sure. And you can find this slide and all of these were screen grabs from the epidemiologic profile.
Great. And we have time for one last question. I see Dr. Carla Wagner with her hand raised. I'll turn it over to Dr. Wagner.
Thank you, Steve. I'm not on the committee, so I don't know if I'm actually allowed a question. But thank you, James, for your presentation. I want to encourage this committee and the Office of Analytics as you're digging into these data to look at a few things that I am consistently getting questions on and that I've been tracking as I'm looking at national data. One is I think there's some really important regional variation across the state. It's my understanding that overdose deaths have decreased a bit in Washoe County and maybe in the rurals, but not in the South. So as Jessica said, there's a lot of regional variation and nuance that we need to look at and think about how to better target our efforts. The other thing that I want to point out that's really important that James said is that when we're counting deaths that had fentanyl on board and deaths that had methamphetamine on board, and when you're looking at those curves, it's really important to remember that the majority of those deaths are polydrug deaths, and that the polydrug deaths look like opioid deaths. So to really understand what's going on between opioids and fentanyl, we have to understand what share of those methamphetamine or stimulant deaths are attributable to methamphetamine or stimulants alone, not in the presence of opioids. And that's not typically how we display our data, but we need to start looking at it that way. And the third thing that I would recommend is that consistently for the past 20 years, what we know is that the lion's share of deaths are occurring inside, in a residence, if we look at the medical examiner's data, and unobserved. So Morgan shared a lot of data about how much naloxone and test strips we've distributed across the state. If people are dying inside alone, it doesn't matter how much naloxone we've put out there. There's nobody there to witness that death, and that's when people die. So as we look at these data, I think it's important to start teasing out the nuance and the subtlety and the local contextual information that's really going to inform where we infuse resources and focus our efforts to prevent deaths. That wasn't a question, Steve. I'm sorry.
No, thank you, Dr. Wagner. Those were great comments.
Well,
Thank you.
and James Dardis, and I would like to say also that the regional variations that you were talking about can be found in each of those regional variations of the behavioral health epidemic profiles.
Mr. Dardis, we really appreciate you being here today. You've given us a lot to think about. So thank you so much for this great data. And we really appreciate your time today. Thank you again.
Thank you, Michelle. Thank you, everybody.
So our next presenter is Christine Payson. She is the Drug Intelligence Officer for Nevada's high-intensity drug trafficking area, and she is going to present on current drug use and seizure trends in Nevada. So I will turn it over to Ms. Payson.
Thank you. You guys hear me okay?
Yes, we can.
Okay, great. So yes, I am the Drug Intelligence Officer for Nevada HIDA, or High Intensity Drug Trafficking Area. I am not commissioned at all anymore, but I do have a background in law enforcement, and that's how I ended up on the SURG to be a representative for the Nevada Sheriffs and Chiefs Association. Excuse me. So I just want to give you a quick idea of what HIDA is, and then we'll jump into some seizure data and some overdose data, because generally speaking, we can make some pretty good predictions of what our overdoses are going to look like based on what our seizures are. So let's jump into the next slide. Where are we going? I think we're ahead a couple slides. There we go. That's an easy one. No disclosures. Next slide. So, like I said, HIDA is high intensity drug trafficking area. That's federal grant money that's directed toward combating the dismantling of drug trafficking organizations and money laundering organizations. But the other side of HIDA has partnered up with the CDC Foundation as part of the overdose response strategy, or the ORS. And that's my role now. They partnered me with a public health analyst, Lacey Alderson. She works closely with Jessica over there at Southern Nevada Health District. And the whole idea is to marry the two disciplines of public safety or law enforcement with public health, because law enforcement has long known that they're not going to arrest their way out of this overdose problem. So that's how we ended up with this partnership for the overdose response strategy, to take some of that federal grant money and through prevention and education and collaboration, try and wrap our arms around this overdose problem. Next slide. So like I said, it's federal grant money, and they determine what is a high intensity drug trafficking area. And for Nevada, you can see up there in the yellow, that's the Washoe County area, and then in the blue down below, Clark County area. So those are the two designated HIDTA counties within Nevada. But that doesn't mean that we will not coordinate and collaborate with anybody, any of our partners, any of our coalitions throughout the state with our efforts with the overdose response strategy. But it is where most of my data is coming from, because it's the HIDTA analysts in those two counties, which are our most populous counties, that are giving me the type of data that I'm going to be sharing. Next slide. So, like I said, real quick, just to the goals of the ORS, to share some data systems for effective community overdose prevention, support some immediate evidence-based response effort to reduce overdose deaths, design some promising strategies at the intersection of public health and public safety, and then use efficient and effective primary prevention strategies to reduce overdose and substance use in the long term. Next slide. As far as special populations, I decided this covers it all, because the people that are transporting and smuggling these substances in our community, they're equal opportunity. They don't care who buys it, and overdose isn't discriminating either. Next slide. So every year, the Nevada HIDTA does an annual threat assessment, and they determine what the top 4 drug threats are for our area. And you can see them here: fentanyl, followed by methamphetamine, heroin and other opioids, and cocaine. It's not a real surprise that fentanyl is number 1, but if I'd have showed you this a couple of years ago, methamphetamine stayed number 1 in Nevada for years, even though the rest of the country was seeing opioids and definitely fentanyl overtake as their number 1 drug threat. But up until 2022, methamphetamine was still number 1. And finally, in 2022, the assessment determined that fentanyl was now number 1 drug threat, just like we're seeing throughout the US. Next slide. This is the most recent seizure data that I could get. I apologize for that, but I can say with a relative amount of confidence that the next one is going to be fairly similar. But this is just some data, 2021 and 2022, blue being 2021 and the gray part being January to June of 2022 for our top drug seizures. And if you look at it, you can see methamphetamine looks like it definitely is more kilograms being seized, but we still consider methamphetamine to be our number 1 drug threat, just because such a small amount can be fatal. Next slide. So just in 2023, in just pill form in Nevada, 1.7 million fentanyl pills were seized 2023. They're readily available, and there is still a very high demand. Next slide. Then looking at 2024, 37.4 kilograms of fentanyl seized, or 1,216,652 dosage units, compared to 15.6 or 1,753,518 dosage units in 2023. We continue to see powder along with the presence of pressed pills, and we continue to experience an increase in overdose deaths involving a combination of both methamphetamine and fentanyl. Next slide. So you saw on the first slide, it was kilograms, and then the next one I discussed the amount seized as well as dosage units. And we're starting to collect that data in dosage units more and more, because it creates a standardized scale. The dosage units reflects how the drugs are sold on the streets. And we know that the pharmacological effect of a kilogram of one drug can vary 100 times from the pharmacological effect of a kilogram of another drug. So by reporting in dosage units, we're doing a better way of reflecting the life-saving value of each seizure. Next slide. And this just gives you another idea of what that would look like. If you have a kilogram of cocaine, you've got 5,556 dosage units. You move to heroin, it goes up significantly. And then you take a look at our number 1 drug threat. That same kilogram of fentanyl has 672,619 dosage units, or as I like to put it, potential overdose deaths. Next slide. So now looking at our number 2 threat, methamphetamine seizures, we're going from 2020 to 2024. 2020 looks pretty low. And then we jump right back up in 2021 in the yellow there, and that is most likely due to the COVID-19 pandemic and its possible effects. We didn't have many officers out there doing enforcement and seizure type activity, as well as the lack of supply chain coming over the border. But once 2021 and things start opening up a little bit more, we get a good spike. But we do see at least a decline in seizures of methamphetamine as we go to 2023 and 2024. Next slide. And our cocaine seizures, we've got in the green 2021, that looks a really large amount, and then a drop to 2020, a little spike in 2023, and then a pretty good drop in 2024. That 2021 in the green is because it's a large multi-jurisdictional seizure, which caused the quantity to spike for that particular reporting period. And then we get to the next 3 years and it stays fairly close. Next slide. And here we have the same kind of information for 2021 to 2024 of heroin seizures. We're seeing a decline in seizures. We're hoping that that means good news and that will reflect the same in overdoses, but we'll see as that data comes out. Next slide. And like I said, Clark County and Washoe County are the HIDTA counties, so these are the combined fatal fentanyl overdoses alongside with non-fatal overdoses where naloxone was administered, 2022, 2023, and 2024. So we've got a slight decrease in fatal fentanyl overdoses in those two counties from 23 to 24. But as you can see, the suspected non-fatal overdoses where naloxone is administered is going up quite a bit. So the overdoses are not decreasing. The overdose deaths are decreasing somewhat. So I guess the good side is the naloxone is working. We're saving lives, but the overall overdose rate is increasing. Next slide. And as was mentioned earlier, most of the time when we're looking at these overdoses, there's polysubstances on board. So this is just comparing fentanyl related in Clark and Washoe County with a mixture of both fentanyl and methamphetamine from 2022, 23, and 24. Not a huge increase for the methamphetamine and fentanyl, but the fentanyl alone, we're seeing pretty good increases in those overdoses. Next slide. And this just compares them all together by top drug threat. So we're looking at Clark County here, the green being fentanyl, the red cocaine, the yellow methamphetamine, and then the blue being heroin. And we can see fentanyl and methamphetamine definitely still out and proud. Cocaine remains pretty steady throughout, but heroin, there's again silver lining. Those are going down with a pretty good drop from 23 to 24. Next slide. And this is that same top 4 drug threat comparison for Washoe County. Pretty similar. Green bean fentanyl. We got a little bit of a dip from 23 to 24 up in Washoe, and as well as 23 to 24 in methamphetamine. Heroin, pretty decent dip. Cocaine, staying pretty steady. Next slide. And then just to take a little bit broader look, like I said, I wanted to concentrate on Nevada and particularly our HIDTA areas, but it is no surprise to any of us, this fentanyl supply chain is coming up from the south border and being distributed throughout. And this is just a screenshot from the DEA.gov website, which I highly recommend you go visit. It's got great information, not just on fentanyl, but all kinds of other substances. And it'll show you that in 2023, DEA seized more than 28.4 million fentanyl laced fake pills and nearly 12,000 pounds of fentanyl powder. And those seizures for 2023 are equivalent to more than 388.8 million lethal doses of fentanyl. They're coming up, being trafficked by 2 major drug cartels, distributed throughout the United States with the help of some street gangs, and they're being produced in mega labs in Mexico with precursors coming primarily from China. Next slide. Another screenshot. So this is a running tally or ticker that DEA has up of specifically fentanyl seizures. So this is a screenshot from May 2nd of 2024. So for that year, seizures were down a little bit. Instead of 78.8 million pills, they seized 60 million fentanyl-laced fake pills. And instead of 12,000 pounds of powder, they seized 8,000 pounds of powder. So maybe that means that some of the security at the border is working and less is getting through. But those seizures are still equivalent to 380 million lethal doses of fentanyl. Next slide. And then I just took this screenshot. Sorry, that was my personal assistant in the background, if you heard that. Apologize. This is a screenshot from end of June. So halfway through 2025, we're looking to be right even with 2024's. We're already halfway to the well, more than halfway to the 60 million pills they seized in 2024. We're already at 41.5, and the 8,000 pounds of powder from 2024, we're already at 44.63 powder. So we'll see what the rest of the year holds. We'll see what security at the border does, and find out how this at the end of the year, how that compares for overall through the nation. Next slide. These are just some of my references. Like I said, the DEA website, Nevada Annual Threat Assessment, and the National Emerging Drugs Initiative. And I just wanted to reiterate what was said earlier. When you look at those overdoses and deaths, particularly in Clark County, because we have such a tremendous tourist population coming in there, ours is a little more unique that when you're comparing it to other states, because we're not, when we're getting our coroner data, we have an overdose death in Clark County. It's just called it's counted as an overdose death in Clark County, not as a tourist overdose death. Next slide. And that's my contact info. Happy to answer any questions.
Thank you, Ms. Payson, for that great presentation. We really appreciate the very helpful data. And as she just said, does anyone have any questions?
Yes, we have a question here in Las Vegas.
Yes, please go ahead.
Hi, it's Dr. Dixon. I'm always really interested in this kind of data, but I had an interesting experience. I'm one of the doctors who takes care of people that are using opioids. And I had an interesting patient recently who had spent some time in prison for possession. But I was asking him where are you guys getting this stuff from? And I see that you talked about getting it from the border, but he was describing that whoever he deals with is getting it mostly from boats coming in on the California coast. Now, you mostly was presenting Nevada data, but what does the California data look like?
I wish I could answer that for you. You'd have to contact the California HIDA to see what that's looking like. But I would say that even though it's coming in on boats, that it's originating in Mexico, and then that's just their method of getting it in the U.S.
Well, and they seem to be getting it from California over to here, because this was a Nevada person. Yeah.
Yeah.
So,
Once it's into California, that's not a big leap to get it over to here, Arizona, Utah.
I see Jessica Johnson with her hand raised.
Hi, thank you for the opportunity to ask a question, and thank you, Christine, for a great question. HIDA's threat determination. What are the variables, or how do you determine that threat ranking? Are there like particular inputs that the team considers, quantitative or qualitative? I was interested if you could talk about that. And then I have a follow-up question if there's time.
Great question. I'll do my best to answer it. I would say it's both quantitative and qualitative. I know that they're looking at overall seizures, you know, the amount that's coming in. But I also know that there's an extensive survey that is sent out to all of the detectives that are part of these task forces, the boots on the ground. What are they seeing? Survey going out to our lab people. What are they seeing? Potency. And those are the ones I can think off the top of my head. I could probably get you a more comprehensive answer if I quiz the analysts that actually put this great information together.
No, that was really helpful. Thank you. My second question is, I was wondering on the seized data. Are you aware if there's any testing that's done? I don't know if it's publicly shared or not, on the data that's seized. Like, for example, do they have a sense of any type of adulteration? I'm thinking about things like xylazine, or the East Coast has seen some medetomidine, if that's in what's seized here or being seized like prior to entry. And then if they have any sense of like the quantitative testing of the substances, or is it kind of really just qualitative?
They are testing, I can tell you that. I know that we've seen xylazine, but to really answer that question, that's for the lab geeks. I'm not even going to pretend to know how to answer that, but I can put you in contact with someone who can.
Oh, wonderful. Thank you so much.
You bet.
Ms. Payson, thank you so much for being here today. We really appreciate your time and look forward to continuing to work with you. So thank you again.
My pleasure. Thank you.
Okay, next we have Dr. Carla Wagner from the University of Nevada, Reno School of Public Health. She is going to present on drug testing performed by public health programs. So I will turn it over to Dr. Wagner. Great to see you.
Thank you. And thanks everybody for the invitation. I'm really happy to be here today. I am a professor in the School of Public Health at UNR. And what I'm going to do is just give a brief overview of this emerging public health strategy of providing drug testing for public health purposes. So Jessica was just talking about testing seizures. What we're talking about is testing drugs that people who use drugs bring us for analysis. Next slide. And then hopefully this is just going to kind of give you a 101 about what this is. And then Marco's going to tell you a little bit more about how things are working in Southern Nevada. Before I start talking about this, I just want to acknowledge that nothing I'm saying here today is a product of my own work in isolation. That drug checking, like every other harm reduction strategy we have for addressing opioid and other drug overdoses, was born largely out of grassroots efforts by and for people who use drugs. And this was done in the context of community care and community mobilization. What I mean by that is that people who use drugs have always been at the forefront of developing programs to reduce the morbidity and mortality associated with using drugs. And that's true for naloxone distribution, which was started by and for people who use drugs in 1996 in Chicago, and continues on today as people are trying to address the increasingly toxic, volatile, and unregulated drug market. So I just want to say that to contextualize, this is not my own work. This is a community's worth of work. And that the slides I'm presenting today also rely heavily on work that was done by others, Nab Dasgupta and others at the University of North Carolina, Chapel Hill. Next slide. So imagine you are a person who is living with a nut allergy. You've had this allergy for your whole life. You know how it affects you. The symptoms used to be mild, like tingling in your throat, and you used to get some hives. But then as you've gotten older, you've noticed that ongoing exposure that you used to tolerate has resulted in more severe reactions. The last time you ate nuts, you experienced difficulty breathing, swelling of your tongue and throat, and you required medical intervention. So now you carry an EpiPen in case you experience that severe reaction again, so that you or somebody who's with you can administer the medication in case you've been accidentally exposed. So obviously, giving these changes to your health and well-being, you're going to try to make safer choices about what you expose yourself to in the future so that you don't trigger these unwanted effects. So you're at the store, you're buying a bag of pretzels, and you're trying to choose between these two bags. You know that they're both pretzels, so probably either one is fine, right? Next slide. Until you turn it over and you take a closer look at the ingredients list. The one on the left has a warning label that tells you that it was made in a facility that may use peanuts. There's no nuts in the ingredient list, but the information on this warning suggests to you that the pretzels in this bag might have inadvertently come in contact with peanuts, and that might increase your negative response. So given your sensitivity and the seriousness of the symptoms that you've experienced, you obviously choose the pretzels on the right. Next slide. Same scenario, but this time you're at an afternoon barbecue. You're deciding between two drinks, one that contains 20% alcohol by volume and one that contains 2.4. You've got a lot of work to do this afternoon, and while you want to have a drink, you need to keep your wits about you. So you choose the Radler with 2.4% alcohol, which is clearly labeled as such, so that you can make the safer choice for yourself in that situation. Slide. So you see where I'm going with this, right? The illicit drug market is completely unregulated. We don't have an ingredients list to tell us if there are potential contaminants in the drugs. We also don't have information about the potency of the desired ingredients in the drugs. So people who use drugs are trying to make choices to stay safe, but they don't have any of the information that consumers of alcohol or other regulated products have. If you're lucky, maybe the drugs have some sort of color or image on them that can be used to identify which dealer they came from, but often that's not even the case. So the research that we're doing at UNR with people who use drugs suggests that people are doing all kinds of things to try to keep themselves safe in this unregulated environment. That includes buying from trusted sources, using sensory cues like color or texture or smell to see if they can identify contaminants in their drugs like fentanyl. And you can imagine all the ways in which those kinds of strategies might go wrong for somebody. Next slide. So this is where public health drug checking comes in. There's a range of technology that can be used to provide various levels of information about what is in unregulated drugs. The technology has been around for decades. It's been used in criminal legal systems like crime labs for years and years, but now we're kind of repurposing it for use in community settings to inform public health priorities. So this is a continuum on this slide in terms of cost, time, complexity, and information provided by different technologies. On the left, you see fentanyl test strips, which you've heard about, which were originally created for use in urine drug screens, but now they're more widely available so that people can test their drugs for the presence of fentanyl before they use them. Test strips provide a qualitative test result. What I mean by that is it just tells you yes, no, presence or absence of the thing that the strip is looking for. They can't test for anything else, and they can't tell you how much. They can just tell you yes or no. Because test strips and reagents kind of do the same thing, but they're used on a tabletop and they're color coded and they turn a different color depending on what they're exposed to. Because test strips and reagents can only tell you about presence or absence of the drug that they're looking for, their programs are increasingly looking to other kinds of technologies that can give us more information. So that moves us to spectrometers on the right side of the screen. Spectrometers analyze the molecular structure and the composition of the substances they're testing and provide kind of a unique fingerprint of what is in that substance. So the device on the far right is a liquid or gas chromatography mass spectrometer, is the most sophisticated. This is what they're using in the toxicology lab and in the crime labs. It basically separates the substance into its component parts, and then it tells you everything that's in it. So you can see how these different technologies answer different questions. On the left, with test strips, we can ask the question, does this substance have fentanyl in it? Or does this substance have xylazine in it? And you get a yes or no answer. On the right, we can ask the question, what is in this bag of powder? And we get an answer that tells us what all the various components are, and depending on the technology we have, how much of each is present. Next slide. There's trade-offs here in terms of the technology. Test strips, which we now have for fentanyl, benzodiazepines, and xylazine, can be used basically anywhere by anyone. You can carry them in your pocket. You dissolve a bit of drug in water, dip the strip, and wait for the results. They're low cost, but they don't give you lots of information. On the other hand, the mass spectrometers can tell you a lot more information about the content and the purity of the drugs, but it's much more expensive, takes a lot more time, and needs to have the laboratory infrastructure and personnel to support it. Next slide. I just want to show you what a fentanyl test strip looks like. So this is the result you get from a fentanyl test strips, just like the COVID tests, except it's backwards. When you expose the strip to the drug solution and wait for the red lines to appear, 2 lines means no fentanyl, means negative. 1 line means yes fentanyl, fentanyl positive. And that causes a problem for people who were used to reading pregnancy tests or COVID tests or other kinds of test strips because it's different. Next slide. On the other hand, this is what you get when you process drugs through a mass spectrometer. It shows you across the bottom axis, you see all the different peaks, and those peaks occur at different points depending on what's in the substance. So, and here you can also distinguish between the actual substance of concern and the fillers. So you see the highest peak towards the right are about 19.5. That's fentanyl. The peak at about 18 is, I think, a metabolite. And then the box of little peaks to the left, that's all kinds of fillers and cut that also exists in that bit of powder that they tested. Next slide. When these kinds of drug checking programs are functioning for public health purposes, they can provide detailed analysis on every sample that they take and then report out in a public-facing website. So this is an example of one of those drug checking programs. It's called Arrowhead. It's one of the longest standing ones and an international program. And what they've been doing is offering mail-in services. So people actually mail in tiny samples of the drugs that they get online. And then people can go access this website and look up their samples and find out what was in it. So I'm just showing you an example here from Austin, Texas, where you can look at this blue M30, for example, on the left was submitted and somebody thought it was an M30 and it came back positive for fentanyl and fentanyl metabolites. You can look at the one down below, that second M30 that's lower in the list, also bought as an M30, but the only thing that came back was acetaminophen. So this was a completely fake pill, had no fentanyl in it. So this is the kind of information that people can get out of public health drug checking programs. And then we can look at this over time. Next slide. So if you put yourself back in the shoes of that person who was living with a nut allergy, you can imagine how scary the world would be if you had no information to help you avoid the life-threatening consequences of inadvertent exposure to something that might make you stop breathing. So public health agencies are scaling up drug checking programs to address that concern, right? We need more information about what's in the drugs that people are using. We need more information. And when people have that information, they make safer choices. Research shows us that people who use drug checking programs make safer choices about when and how and with whom they use drugs and whether they use the drugs that they have. Next slide. We can use the results from public health drug checking in a number of different ways and at different levels. At the individual level, people get more information about what's in their drugs and they can make safer individual choices. At the community level, we can use this for surveillance purposes, right? We can triangulate this with the data from the seizures and the data from the medical examiner's office and the data from the ERs to help us stay on top of emerging threats, warn people about bad batches or particularly toxic or contaminated batches of drugs, and monitor what's going on in real time. We can use this to inform emergency response. We can use this to inform emergency communication. Without this kind of information, our best surveillance data come from the toxicology reports. that are done after an overdose death. That's the most detailed information we get. And you can see the problem with that, right? We can't wait for people to die to learn what's going on in the drug supply. We have to get the information earlier. Next slide. So well-designed public health drug checking programs are deeply integrated with and informed by the community of people who are using that service. It's not just surveillance. It's a program that's set up to promote autonomy among the people who use the service and provide them with the information they need to make safe choices. It's designed with and by the community who uses it to connect consumers of the service to the public health infrastructure and technology, but we do it with them. We don't do this to them. And in turn, it returns information to the community as quickly as possible so that we have near real-time information pipeline that can alert us about new threats before people start dying. We don't want our emergency rooms and our medical examiner labs to be the sentinel surveillance sites. We want drug checking to tell us first. Next slide. The research tells us that people in the US, or the research tells us that people are concerned about the risk of drug use. People are motivated to use these programs, and that when they do, they change their behavior to address the risks that are identified. As with any public health service for people who use drugs, there's obvious barriers to overcome, mostly due to the criminalized nature of drug use. People are really worried about criminal legal consequences for participating in programs like this. And just like the 911 Good Samaritan laws that are designed to address those fears for people calling 911 to respond to an overdose, we need to make sure that these programs are established in a policy environment that protects people from the consequences that they worry about and make it easier for them to access these programs so that they can make safer choices. In Northern Nevada, UNR has a grant via the state opioid response program. We are just developing a comprehensive street drug surveillance program, and we're doing this with a lot of assistance from Southern Nevada. Thank you, Jess and Marco and everybody on your team. So we are collecting samples provided by community members that we're going to send to the National Institute for Standards and Technology, which is a federal lab. And then we're also going to triangulate these data with data from the Washoe County Forensic Lab on the contents of drugs seized by law enforcement officers, and from the Washoe County Medical Examiner on the results of toxicology tests from decedents. And so the idea is that at UNR, we will become a data warehouse where we can collect samples, warehouse and analyze the data, and then disseminate that via data dashboards and community-facing materials, and ideally integrate with all of these other surveillance mechanisms that we already have established in the state. And I will leave it there. But I'm giving you links here if you want to look at how other people have done this. These links are wrong, actually, and I updated them on my slides, so I will send Crystal better links.
Dr. Wagner, thank you so much for another great presentation today. We really appreciate you making time to be here again. So on that note, does anyone have any questions for Dr. Wagner? I see Jessica Johnson with her hand raised.
Yeah, thank you for the opportunity to ask a quick question. Jessica Johnson for the record. Thank you, Dr. Wagner, for a great presentation on kind of the history and the work that your team's doing to scale up in Northern Nevada. I was wondering if, since you're so familiar with some of the research nationally and the work, has there been a sense or kind of any reports about if there are different substances or maybe risks among the people who are using drugs who aren't accessing these types of drug checking programs, and any ways to kind of think about addressing barriers or preventing overdose from that perspective?
Thanks, Jess. Carla Wagner here. I missed the critical part of your question. Has there been any research on what?
Oh.
People who are using drugs?
Oh, on for people who use drugs who are not accessing these types of programs, if there are any type of like either different risk profile or even maybe substances that that might be missed. I mean, I guess it's kind of a we don't know what we don't know sort of question, but I'm just curious if there's been any research on identifying what some of the barriers are.
Wow, that's an interesting question. That I don't know the answer to. But I do think what it makes me think about is the opportunity to triangulate these different data sets, right? What we're going to try to do, and we can do it, what we're going to try to do is bring together the data from the seizures. So law enforcement seizures provides data about drugs that have not yet made it to the street, right? That people have not yet used. Drug checking data will provide data about drugs that people may or may not have used. And medical examiner data will provide data on drugs that people did use. So I think we can try to get closer, but I don't know. That's a really important question. And it just makes me want to reiterate what I said before, is that there is clearly a large share of the population that is not connected to life-saving harm reduction practices, because those are the ones that are showing up in the death data.
Thank you.
Dr. Wagner, thank you again for being here today, and we look forward to continuing to work with you. So thank you again. Okay, next we have Marco Mendez. He is a public health evaluator with the Division of Disease Surveillance and Control at Southern Nevada's Health District. He is going to present on the surveillance of the Clark County illicit drug supply. So next I will turn it over to Mr. Mendez. Hello.
Hello. Thank you. Good afternoon, everybody. So I am Marco Mendez, Public Health Evaluator at SNHD. Thank you for inviting me today to speak about some recent findings and trends in our Clark County local illicit drug supply. I hope that this presentation is helpful in providing some context to this work group's discussions and some policy recommendations to keep the communities throughout our state safe and healthy. So before we dive into some more data, just wanted to note that these surveillance activities are conducted as part of OD2A local efforts and funding from CDC. So just as a quick intro, and this may reflect some of what Dr. Wagner was mentioning earlier, our drug checking program at SNHD was launched in September of 2023 as part of our OD2A local funding, with full-scale sample collection operationalized in roughly February 2024. When I say full scale, I mean that all three of our sample collection partners were fully up and running by then. And those are the SNHD Linkage to Action team, the center, which is the local LGBT center in Las Vegas, and of course, Impact Exchange, the syringe services provider within the state. So this program, it takes samples from residues on used drug paraphernalia that community members voluntarily submit. These paraphernalia items would otherwise be discarded by community members. So essentially, we are taking samples of residues on people's trash, you could say, quote unquote. The primary goal of our initiative here is to monitor the local illicit drug supply and identify and track trends in that supply to inform our harm reduction and overdose prevention efforts throughout Clark County. So this initiative also allows us to detect novel adulterants within the drug supply to stay as ahead of the curve as possible. And this is done in collaboration with the Rapid Analysis of Drugs program, and that's housed within NIST.
Excuse me, sorry, just a moment. Las Vegas just got kicked out. So if you can hang on just for a second, they're going to try to dial back in. Little technical difficulty today.
Thank you, Laura.
Yeah. We keep a side track on our phones with the text group so we can keep track of the different locations, what's happening, and they're working on trying to get back in.
Oh, okay, it looks
There we
like,
go.
looks. Should we do a sound check, just making sure Las Vegas, can you hear us?
Yes.
Yes, we can hear you. Can you hear us?
We can hear you, Terry. Thank you.
Okay, you can proceed, Mr. Mendez. Thank you.
All right. So, as I was saying, the primary goal of our initiative is to monitor our local illicit drug supply, trends in that supply, and also detect novel adulterants before they become a big issue within the community. So this is done in collaboration with the Rapid Analysis of Drugs program. And that's housed within NIST, which Dr. Wagner mentioned is part of the National Institute for Standards and Technology. And this allows us to get qualitative readings from each of these samples to at least determine whether or not certain substances are present within a sample, and not necessarily the amount of each substance. So here, as we dive in, we just have a breakdown of the different item types that have been sampled. So we're, for this presentation, going to be looking at February 2024, which is when we reached full-scale operation of sample collection, through May of 2025. So as you can see, the majority of our samples come from syringes. That's 54.2%. And almost 30% of all of our samples came from smoking or snorting supplies. So these are straws, pipes, and chores. The remaining 16.7% are spread out among other paraphernalia types that clients have voluntarily submitted for sampling. So this graph here is showing 35 total samples. So among our 2,438 samples that were collected over this time period, 35 or 1.4% showed detection of fentanyl without any other adulterants or compounds. So this is samples that read only as fentanyl. The highest number of detections was in August of 2024. And again, I'm just going to reiterate, these are qualitative findings. So they don't give us information on the amount or proportions of each substance detected within a sample. So I'm going to be very careful not to use the word pure, since I can't say that with certainty, since these are qualitative. And then here, we can see the number of samples by month over this same period that contain fentanyl and at least one other substance. So this could be anything from meth, heroin, cocaine, etc. But essentially, these are any sample that had fentanyl plus something else. So out of all of our total amount of samples for this time period, this is about 9.7%, or 366 samples. And while some of these samples may have been adulterated with fentanyl, meaning the person who submitted it did not know that fentanyl was supposed to be in that drug that they were using, other samples may have contained fentanyl and the person did know about it, right? So there are some folks who do look specifically for fentanyl when looking to acquire their substances. But altogether, this trend of fentanyl detection in mixtures appears to be roughly increasing over time as we continue to move forward. Next slide, please. Okay. And then looking at these same 366 samples that contain fentanyl and at least one other substance, we have noticed, looking at this breakdown of item types, that these mixtures were typically seen in straws submitted for sampling. So that suggests a route of administration of snorting or intranasal, since the items used were straws. But the next most common paraphernalia type containing these mixtures was pipes and chores, so suggesting a route of administration of smoking. So what we can glean from this is that most likely, people who are consuming substances that have fentanyl and something else in it are either snorting or smoking those substances rather than injecting them. Next slide, please.
That's what they tell us.
So taking a step back from fentanyl for a second, here we can see 1,407 samples that contained only methamphetamine. So there was no fentanyl or any other substances in those detected. And this represents actually 57.7% of all of the samples taken during this time period. And as you can see, if you were to imagine a trend line over this, that it looks like it's roughly decreasing, right? So we're seeing less and less methamphetamine only in these samples and more samples over time with methamphetamine and other substances or fentanyl and other substances, etc. Next slide, please. So to kind of visualize that a little bit, this graphic here is showing, visually at least, the proportion of samples containing methamphetamine only in the sort of gray color. And then the yellowish bars show the proportion of samples containing methamphetamine and fentanyl specifically. So for the most part, the proportion of these samples containing methamphetamine only is typically larger than the proportion of samples containing methamphetamine and fentanyl. Next slide, please. And then sort of translating those yellow greenish bars into proportions, this line represents or displays those proportions. So we can see here that the proportion of methamphetamine containing fentanyl increases between April and May 2025. I will note, though, that at the time this analysis was conducted, results from samples taken towards the end of May were not yet available from our partners at the NIST lab. Since then, that proportion has decreased slightly, but either way, it's kind of an inverse of what we were looking at earlier when we were looking at the meth-only detections, right? That was decreasing over time, and this is increasing. So something to watch out for. Next slide, please. So if we wanted to look at methamphetamine that is present in a mixture with other substances, here we'll just say adulterated loosely, but it really just means methamphetamine plus something else. So there were 366 samples that contained fentanyl and at least one other substance. So of those 366, 237 were samples that contained fentanyl and at least methamphetamine. There could have been other things in there, but they at least contained meth and fentanyl. And that represents 64.7% of those 366 samples. And then looking at the co-occurrence of methamphetamine and fentanyl, this was identified mostly in straws, right? So if we're drilling down to the 237 samples that contained meth, fentanyl, and maybe some other things, 165 of those, or 69.6%, were so again, suggesting a snorting or maybe even smoking route of administration. Those same 237 samples, when put in the context of all of the samples taken, that represents about 9.7%. So we can say roughly 10% of all of our samples taken over this time period contained meth and fentanyl, and maybe other things, but at least methamphetamine and fentanyl. Next slide, please. So as with all data, there are some limitations to keep in mind when interpreting them, right? So mainly, these data are convenience data. They're voluntarily submitted by community members who are seeking harm reduction or other services through our mobile outreach team or through our other sample collection partners at the center or at Impact Exchange. So therefore, these data are dependent on continued rapport with the community to continue to receive samples. Another limitation is that samples are taken post-use, which Dr. Wagner was speaking about earlier. So it's not possible to reliably know how many times a particular item was used, how many individuals may have used that item, how many and which substances were used by the person volunteering their item. So what I'm getting at is that there may be contamination of previous drug use. So by the time we sample it, we might see that there were 3 substances present in a sample, but the person who submitted that item maybe was told when they acquired it that they were getting just 1 substance, right? And that may be true, but with contamination from previous uses, it would read differently once it gets to the lab. And then, of course, a big one, NIST is not located within Nevada. It's actually located in Maryland, since it is a federal entity. So mailing or other logistical issues may also impede the timeliness of these data, since everything does have to get mailed across the country. I can say that typically, from the time that samples are received by the lab, we typically can see results within 72 hours to a week. So while it's not ideal, it's better than not having this information at all. Next slide, please. And then similar to previous presentations, primary populations of focus for this initiative and other overdose prevention initiatives is essentially anyone who uses drugs or who may use drugs. They can belong to any demographic group, racial group, ethnic group, sex or gender. However, other populations that are disproportionately affected by substance use disorders, I've listed here. So some of those might be justice-involved adults and youth, people experiencing homelessness, our queer community, and others. Next slide, please. So what I want to highlight here is sort of what's been working well since the launch of this program. So something that we're very thankful for and that we strive and work hard to maintain is that community rapport and receptiveness to this initiative. This can partly be attributed to our sample collection process being entirely anonymous. We don't collect any personal identifying information at all when folks are submitting their paraphernalia for sampling. Each sample is assigned a numerical unique identifier by the lab, but these aren't linked to any identifying information for the people submitting. So there's no way to trace which specific person may have submitted which samples. And what we've been able to do with these data since launch is actually inform our prevention work in Clark County. And that even includes what educational talking points our outreach team might use based on what adulterants we're seeing most commonly in a given month or a given quarter. And this can also inform, of course, where we're distributing naloxone and test strips, and where we may be conducting our biweekly outreach events with our internal team. Next slide, please. But despite the initiative, this is only limited to Clark County. So a continuing gap in service that I would point out is a lack of community accessible pre-use drug checking, especially in Clark County. So like I said, these data collected are post-use. So while these trends that we're seeing may inform future directions for prevention activities, real-time on-the-spot drug checking data aren't yet available for us. But that would definitely boost harm reduction and educational efforts to be able to counsel people prior to use rather than after. Next slide, please. So keeping all of this in mind, some recommendations to consider might be to continue to scale up regional laboratories within Nevada to test samples and substances with high throughput and sensitivity. And this will also help us keep track of regional nuances in drug supplies, especially because there are differences between northern and southern Nevada's drug supplies and drug distribution routes. I would also put forth maybe increasing the number of accessible sites for the community to submit paraphernalia for this type of testing, and also to continue to expand harm reduction centers. I'm sorry, I see my time is up. I have one more slide after this. That'll be quick. To expand harm reduction centers, and considering even the implementation of overdose prevention sites, where people can have more immediate response, especially in the case of an overdose. And then further expansion of 24/7 access to free naloxone. Especially, since I would be preaching to the choir here to say that we know that fentanyl may be present in lots of different substances. So of course, naloxone would be a great first line of defense in case something were to go awry during use. Next slide, please. So for some references here, these actually might be more helpful references for the group. The first one I'd like to point out is our SNHD substance use dashboard. Our epidemiology team and me update this monthly on the 15th. So we'd like to keep it as real time as possible. So we update it monthly, and it includes mortality and morbidity data for overdoses in Clark County, broken out by opioids and other substances. It also includes the drug checking data that I presented today, as well as a page of resources for community. So it has maps where people can see different agencies and locations where they can pick up test strips and or naloxone in Clark County. The goal was to make it as a one-stop shop as possible so that folks didn't have to click around between several pages to get the information that they needed. And then the second one I have here is just in case anyone needs it. SNHD has a mail order test strip program. It's for Clark County residents only. But people can request test strips and educational materials. They're available in English or Spanish, and each pack comes with 5 of each type of test strip. So those are existing resources in addition to this data. And then on the next slide is just my contact information. So if there are any questions after this, please feel free to reach out.
Thank you so much, Mr. Mendez. We really appreciate you being here. That was a great presentation. We have time just for one quick question or comment. So I'll open it up to see if anyone has would like to ask a question or make a comment. I see Jessica Johnson with her hand raised. Jessica?
Yeah, I'm also taking a lot of airtime. So if somebody else has a question, happy to pause for a moment if they do.
I don't see anyone else with their hand raised. Oh, I'm sorry.
Dr. Dixon has a question.
Oh, Dr. Dixon, yes.
So I want to ask you, Marco, about testing. We have, I work with the patients, and this is Dr. Dixon, and we have a lot of patients who come in who test positive for methamphetamine, but and this is just the urine testing we can do in the clinic, but almost everyone who tests positive for methamphetamine comes up a strip positive for MDMA or ecstasy. And we're wondering, are they really, and they always deny that they're using ecstasy. And you generally a person knows that they're using ecstasy. Is there something about the test strip that picks up both, even though there's really no ecstasy there?
I don't have a solid answer for that. I'm happy to look it up and reach back out. But there are certain substances that may cause interactions with test strips. One example that, unfortunately, it's not related to MDMA and methamphetamine, but one example of that would be the presence of lidocaine can create false positives with xylazine test strips. So there may be a similar situation with methamphetamine and ecstasy coming up in that scenario, but I'd have to go back and confirm that. So I wouldn't quote me, but that would be my inclination.
Well, that's what we're thinking, but we just wonder if someone knows that, because we don't have, it costs, this is what we do in the clinic. If a patient has a question or denies that they were using, we can always send it off for better testing, but that costs $25 to the patients, and most patients aren't willing to pay that. Thanks.
Jessica, did you still have a quick question or comment before we move on?
I did. Thank you, Vice Chair Shell. Marco, thank you for a great presentation. I was wondering, in the drug checking efforts, what do you see the role of fentanyl test strips and xylazine test strips in the distribution of those playing in the drug checking efforts?
Yeah, I mean, really those test strips would be supplemental to drug checking efforts, right? They would be, at least for now, with the current resources we have in Clark County, they would at least offer some pre-use qualitative testing so that folks could at least know if fentanyl was present before using. So while that may not be ideal still, to not have like pre-use mass spectrometer type testing with that level of detail, it could still serve as a point of sorry, I'm losing my train of thought. It's been a long day, everybody. It could still be a first line of defense, right? To know. So plugging into the drug checking efforts, right? If we are seeing more fentanyl, let's say within the meth supply, right? That could also inform educational efforts and materials. So if we are seeing more fentanyl in meth, for example, then we could tailor educational efforts to encourage folks who are using meth to still use those strips, right? Sorry, I'm not sure if that answered your question.
Mr. Mendez, thank you again for being here today. We really appreciate your time and look forward to also continuing to work with you. So thank you again.
Thank you for having me.
Thank you. That concludes agenda item number 5. We are going to take a 5-minute break and reconvene at 4:08. So we will see everyone in just a few minutes. Thank you all. We'll go back and reconvene our meeting and continue with item number 6 on our agenda. I will turn it over to Dr. Terry Kearns and Laura Hale, who are going to present on changes to our SURG membership and reporting timelines, as well as give us a recap of the legislative session. So Dr. Kearns and Laura.
Thank you, Vice Chair Shell. Terry Kearns for the record. I just wanted to give an update. I think everyone's aware that the Attorney General pushed forward the BDR for increasing membership for the SURG, which was Assembly Bill 19, which did pass. And as you can see, we are adding members to the SURG. Some of them are appointments such as the Executive Director of Department of Indigent Defense Services, and also from Division of Child and Family Services, and then from the Nevada District Attorneys Association. We did recently send out a press release requesting applications for members, one being a member of the general public, preference given to someone from that speaks more than one language and it resides in a household where more than one language is spoken, and then also a person who is an emergency response employee. So those are out there. Please feel free to pass that on or also to apply. And they come to me at my email address. Next slide. I would also highlight that okay, I said the solicitation went out. We're also revising our timeline for reporting that came out of the legislation. It was actually by one of our SURG members and also a legislator, Senator Doniate, who suggested that maybe we change our reporting date so that it is more actionable, because I know not all of our requests for BDRs landed on someone because most already had their BDRs chosen because they come out so late. So we are changing our reporting, and we will now report on August 1st of every year. But till we get to that point, on January 31st of 2026, we will be doing kind of like a progress report. that will, and it will basically describe all the information, present it to the SURG and the subcommittees, but there will not be recommendations in that report. And then on August 1st of 2026, we will be presenting our annual report that does include the recommendations. So the good news of that is it gives us a little more time to develop our recommendations for our next annual report. We'll have until that August 1st date. And I would also highlight that the Fund for Resilient Nevada is in the process of doing a needs assessment. And that's part of that need assessment that needs to be done as part of the opioid litigation settlement. And they will then do a state plan. You remember we got presentations on, the first one was done by Mercer. It's going to be done all more in-house this year. And one of the groups that may be asked for input into that are SURG members. So if Heather Kerwood reaches out to you, I encourage you to talk to her in terms of that needs assessment that will be done. And one other thing that we're going to have to do in a future meeting, because we have the change in the reporting date and the increase in the membership, is change our bylaws. So we'll work on those, and that will be an item that will have to be approved in the future. That's all I have.
Thank you so much, Dr. Kearns. Any questions for Dr. Kearns? Okay, thank you again, Dr. Kearns. Next, I'll turn it over to Ms. Hale.
Thank you, Chair Shell. Just a couple of quick updates on the bill status report. If we can see that on the screen, maybe the next slide. Okay, thank you. So most of you will have seen this through your subcommittee work, and really the updates are primarily the last column on the status. So you can see where it's indicated if the governor has approved the bill. In some cases, there are different effective dates. Some of them, there was no further action, so they might have been heard in a committee or two committees, and but ultimately did not get passed through the legislative body. If you could move to the third page, there were a couple of things I wanted to highlight there. Yeah, thank you. And so on SB 68, this one, you'll see that it says no hearing. This one was, I was asked to add in here because it is related in terms of this social worker licensure compact. Because it never got a hearing, I wasn't tracking those bills, but it certainly is something that the SURG members might be interested in for the future. And then under SB 231 down at the bottom, I just wanted to note this one has some different effective dates. So sometimes regulation or administrative work takes effect at different timeframes than the rest of the sections. And one of the things I wanted to say about bills that have had, excuse me, have had a hearing versus one that does not, oftentimes, you know, a lot of bill draft requests go into the Legislative Council Bureau. Not all of them get even a bill draft actually written, and then some don't ever get a hearing. Some may be heard in one side of the House and not the other. It doesn't mean, usually if it got approved and it made it partway through the legislative process, then there's some level of support for those. So those might be good things for SURG members to look at. You could even go back and listen to a hearing or try to find out, you know, was there some reason it didn't make it all the way through? You know, in this case, a lot of bills didn't make because they just ran out of time. So I would say there is quite a difference between a bill that doesn't get a hearing and a bill that's had a couple of hearings but just didn't quite make it to the end. And then the one other thing that I would call your attention to is on the 5th page, SB 457. That did have some language in there that impacted previous surge recommendations that had passed. And ultimately, the governor took out that particular section, but it's my understanding that this, if there is a special session called, that this bill might resurface. So it's just something to keep an eye on. And that's all I have, unless people have any questions for me.
Thank you, Ms. Hale. Do we have any questions or comments for Ms. Hale? Okay, thank you again, Ms. Hale, and thank you, Dr. Kearns. We appreciate it. Moving on to item number 7 on our agenda, includes subcommittee reports. So I will first turn it over to Jessica Johnson, who was chair of our prevention subcommittee.
Vice Chair Eric Schoen, for the record, I have been asked to step in for Jessica Johnson because of the tenuousness of her connection where she's at traveling.
Yes, please, Mr. Schoen. I'll turn it over to you. Thank you.
Okay, so we have been busy reviewing progress on our prior recommendations with the idea that we are trying to figure out which recommendations to continue moving forward and which new recommendations we might consider to include on the next report. In order to do that, we've had several different presentations, as you could see listed on the screen. The first one was on low barrier emergency department-based naloxone distribution, which is interesting for the intricacies. You would think that emergency departments would be a place for easy naloxone distribution. It is a place for distribution, but there are nuances that make it not always so easy. So better understanding perhaps what we might be able to do to support more ready distribution through emergency departments. The second presentation there was an update on the multi-tiered system of support project that is basically offered throughout the school, many schools throughout the state, to make sure that students have access to needed supports in their families and what we might be able to do to help support that. And then lastly, the Boys and Girls Club of the Nevada Alliance Fund for a Resilient Nevada Smart Moves program. It's a program they've started to try to address the social emotional learning needs of kiddos so that they have some resiliency when it comes to not becoming involved with drugs and alcohol, being able to say no. Our future presentations might include such things as what we've listed there, how to adjust existing recommendations related to cannabis and tobacco to make them more actionable. That was one of the pieces of feedback we heard loud and clear from both Senator Doniate as well as A.G. Ford, that our recommendations, we could have aspirational recommendations, but it would be better if they were actionable and more specific so that folks could more easily take those forward. And just to give you an idea, I think of some successes. I think sometimes those of us serving on this committee and on the subcommittee sometimes wonder if our work makes a difference. I think one big success out of this legislative session was that prevention specialists were recognized and are now certified, can now be certified. It wasn't that long ago. Let's go back 10 years ago. We didn't have community health workers that were certified, nor did we have peers, and now we have all three: community health workers, peers, and now prevention specialists. And I think we're finding out how potent all three of those professions are for helping us to develop the needed workforce. So I'm excited to see what that might bring. And then also, even though I don't know that we made it a very actionable recommendation, we had conversations about the importance of making sure that we could do drug surveillance as discussed by Dr. Wagner and Marcos. And so I'm really pleased to hear the efforts that they have described and are bringing that forward. I think the more specific information we can have about the drugs that are out there, the more we should be able to hopefully provide some good interventions. So I'm happy to entertain any questions folks might have, but we've been busy.
Any questions or comments for Mr. Schoen? Okay, Thank you, Jessica, and the Prevention Subcommittee. We appreciate you. Moving on to the Treatment and Recovery Subcommittee, I, Steve Shell, will provide a report on this subcommittee. We have also been reviewing progress on prior recommendations that we have made just to look at what might have been, produced in this last legislative session and what we might want to continue to propose to SURG in the follow-up meetings. In terms of presentations, we did receive a presentation regarding our one proposed recommendation that was submitted by Chelsea Cheatham. The recommendation is a retrospective assessment and/or prospective study would be conducted to assess the outcomes of patients following discharge from detoxification and examine mortality and overdose. So we had a presentation from John Hamilton, who is with Liberation Programs in Connecticut, and he and his programs have done a lot of work around outcomes and particular measures of their outcomes. So it was very interesting to hear their presentation. We also received presentations from John Firestone. He's Executive Director of the Life Change Center in Reno, and he presented on CFR 42 Part 8 that focuses on updating regulations for opioid treatment programs. And then we also received a presentation from Dr. Jose Maria Pardita Corona with the Pardita Corona Medical Center in Las Vegas, who presented on trends and opportunities related to substance misuse treatment. And then we had a great presentation from Ms. Hale, as she just presented today as well, but it was a very thorough presentation on legislation that passed in this last session, but also some legislation that did not pass that we need to keep on our radar for the future. And then regarding future presentations, we are lining up a presentation on treatment modalities, and then we are currently workshopping 2 recommendations at the moment. So that is it for the Treatment and Recovery Subcommittee, unless anybody has any questions or comments for me. Hearing none, we will move next to Dr. Terry Kearns, who chairs the Response Subcommittee. So I will turn it over to Dr. Kearns.
Thank you, Vice Chair Shell. So as no big surprise, the Response Subcommittee also reviewed our progress on prior recommendations, as did all of the other subcommittees, to get a better feel of whether we should look at old recommendations or come up with newer recommendations. And we've had several presentations. One presentation was on the Good Samaritan Drug Overdose Act, community education and prescription take-back programs. That was presented by Jamie Ross and Daria Singer, both with Prevention Coalitions. And then we had a presentation from Dr. Morgan, who sounds like has been busy on the Emergency Bridge program, and looking at that, not so much from the treatment aspect, but more so looking at it from response and starting people on medication in the emergency room, or also there's a piece of this that looking at paramedics also being able to provide, their community paramedics being able to provide treatment or to be able to provide doses after they're started in the emergency room, because we, as was highlighted in our public comment, getting into treatment is sometimes not as easy as we would like it to be. So that was a good presentation and some good suggestions from Dr. Morgan. We also had a presentation on medication-assisted treatment and medications for opioid use disorder access in certified community behavioral health clinics. Once again, this was looking not so much at the treatment, but looking at access for those people in primarily our rural communities and their capacity to be able to get into these programs. We also had an update on wastewater surveillance of high-risk substances in our state, and that has been a program that's been funded by the Fund for Resilient Nevada and is really just starting to get up and running. So hopefully we'll hear more on that. That was a recommendation from the Response Subcommittee. We hope to have future presentations on workforce and workforce development, defining recidivism, and a program out of Washoe County Sheriff's Office on desistance was highlighted to us. So we hope to have a presentation on that as well. And then the name of this one doesn't really highlight what we're looking for in it, but drug and alcohol presentation, education, and enforcement. If any of you have ever heard of or been to a presentation by the Tall Cop, it's looking at the some of the emerging things that he's seeing, and this is over-the-counter stuff. He goes to like convenience stores, vape shops, those kinds of things. So, and that ties into one of the 2 recommendations that our subcommittee is currently workshopping.
Great. Thank you, Dr. Kearns. Do we have any questions or comments for Dr. Kearns? Okay, thank you again, Dr. Kearns. So that concludes item number 7. We move on to item number 8 on the agenda, which is review and consideration of items for our next meeting, which will be held on October 8th. So I will turn it back to Dr. Kearns.
Thank you, Vice Chair Shell. Of note, our next full SURG meeting is scheduled for October 8th, 2025 at 2 p.m. And we do have confirmed or planning on presentations for medication for opioid use disorder in the rural jails. That's confirmed. We also have the Clark County Regional Opioid Task Force, which has been confirmed, and updates from DHHS, which Laura Hale is working on getting that information. And then, as was suggested by Stephanie Cook, we're hoping to have a presentation by DPBH on their strategic plan. So that's what we have. If anyone else has suggestions for the full SURG, by all means, please provide those to myself or to SEI. And that is considered our first quarter meeting for 2026. And we'll be looking to approve our progress report at that time, which again will not include recommendations, but will just be a progress of where we're at. Our January 2026 meeting, which is the second quarter for 2026, any special topic presentations, and then for the approval of our final progress report. April of 2026, we have, which is our third quarter, review our preliminary recommendations from each of the subcommittees. And then in June of 2026, may need an additional meeting, or it will be an additional meeting to approve that 2026 annual report that's including our recommendations. So we'll have to finalize our recommendations. And then, of course, July would be to approve the 2026 annual report. So we'll have probably a little bit higher tempo of SURG meetings just because we're switching. And after that August 1st annual report, it will be annually in August after that. So 2027 would be when the next one is due as well. So that's where we are at with our upcoming meetings for the SURG. As well, which I forgot to mention on my earlier update for AB 19, is the subcommittees may want to look at the tempo of their meetings, because with the change, we may not need as many meetings, but the plan is that each of the subcommittees will still meet the same number of times. So we don't want one committee to meet like 8 times and the other to only meet 4. So, but it doesn't have to all be at the same month. They could be different months. So for example, we have some confirmed speakers for October for the response subcommittee. So we will be meeting in October, but may not meet one of our other earlier summer meetings. So I wanted to highlight that, which I failed to highlight earlier.
Great. Any questions or comments for Dr. Kearns? Okay, thank you so much, Dr. Kearns. Moving on to item number 9, public comment. Public comment shall be limited to 3 minutes per person. No action may be taken upon a matter raised during a period devoted to comments by the general public until the matter itself has been specifically included on an agenda as an item upon which action may be taken pursuant to NRS 241020. So on that note, I will open it up to public comment. I do see that Assemblymember Golding has her hand raised. I will turn it over to her.
That is a mistake. I'm so sorry.
Oh, no worries, Assembly Member. Thank you. So on that note, do we have anyone wishing to make public comment?
Terry Kearns.
Yes, Dr. Kearns.
Yes, I just wanted to highlight, this is a bit of a PSA. This flyer went out to all the SURG members, but it's also available on the Attorney General SURG website for materials for today's meeting. The Christine Payson, who gave us our earlier presentation about the drug trends, provided this. It's from the Overdose Response Strategy. It's Trends, Analysis, and Threats webinar, and it's a bi-monthly webinar series delivering briefings on current and emerging drug trends from experts with leading forensic and toxicology labs. And I will say that I did spend an hour listening in on this webinar for the July meeting, and it was one of the best hours I've spent. So it's not only on seized drugs, but they also present information from drug checking programs as well. It obviously isn't specific to our state, but they do give regional trends that they're seeing, and also do talk about novel and emerging drugs that they're seeing as well. So I highly recommend it if anybody would like to register and listen in on those.
Thank you, Dr. Kearns. Do we have anybody else wishing to make public comment today?
Mr. Vice Chair, this is Kelly Marshall for the record. I'm just going
Yes.
to read what is printed on the screen for anyone who may not be able to see it to ensure that we comply with every aspect of open meeting law.
Thank you, Ms. Marshall.
So if you're dialing in from a telephone, please dial 719-359-4580. And when prompted, you can enter the webinar ID 841-1615-6896. And then the meeting passcode is 676835. And you can press *6 so that the host can prompt you to unmute.
So on that note,
I do see
yes.
that Scott has her hand raised.
Yes, Ms. Scott, please proceed.
Thank you so much. I just wanted to talk, just make a couple comments. I saw a couple of times we were talking about like workforce development, and I just wanted to just highlight that there was a bill that was passed, and I apologize, the number escapes me. Oh, sorry, this is Beth Scott with Nevada Medicaid. That there was a bill that was passed that creates a pipeline of workforce development through UNR for behavioral health practitioners that will allow the university to be able to be reimbursed for their practicum students who are performing services. So if that's on your radar, that might be something to look into. And I do not know the bill off the top of my head. I apologize. And then the other one that I wanted to, the workforce that I wanted to also second is regarding the Senate bill where the compact license for the social workers didn't pass. I just wanted to bring to your attention that I don't know if it was licensed marriage and families that therapists that passed, or if it was licensed clinical professional counselors that passed. But one of those two professions passed the compact licensing, and they got their bill approved. And I think Senator Dondero Loop, I think, was the sponsor on that bill, but also just might be a piece of nugget to have as you maybe walk that one forward in the next legislative session and you're looking for somebody to sponsor the bill.
Great. Thank you for that great information, Ms. Scott.
Thank you.
Do we have anyone else wishing to make public comment today? Okay, hearing none, we will close public comment. Before we adjourn, we just wanted to thank everyone for being here today. We've had some really great presentation. So it's been a very informative meeting. We will look forward to seeing everyone again on October 8th. In the meantime, please take care. And on that note, we will adjourn today's SURG meeting. So thank you all for being here.